You can begin.
Hello everyone online. Welcome to our Lunch and Learn. I want to introduce you to Mr. Rohit Shetty. Can everybody see us and hear us okay? Please give us a thumbs up.
Where does the thumbs up come?
I think it just pops up.
Wait. Oh. Great. Great. Good afternoon. So thank you, Alec, Holly, Bilal, for organizing this. I'm Rohit Shetty, one of the orthopedic spine consultants based here. So for the next few sort of half an hour or 40 minutes, we can just sort of generally go through. I've got a presentation, I'll put that up, but I think generally go through the challenges which you face in primary care, and then what happens when they sort of come across to us and similar challenges, and sort of how we can sort of work together and move forward and help our patients. So I'll just share my screen. Can you all see that? Okay, so I'm based here at Wellington. I also do a clinic at Princess Grace, and I'm a full-time NHS consultant at Whittington in North London. How do you press the next one?
It's not on that one, is it? No, it can't be.
Okay, fine. So that will be good to have an understanding of sort of back pain and sort of general spinal disorders. And I think when you look at any sort of medical condition, it's good to go through the natural history of a particular condition and saying, when we sort of were to intervene within the natural history, what part we play within the natural history process of an individual medical condition. We can go through some sort of radiological challenges which we have. Nearly all of our patients will at some stage get an MRI scan. And of course, with the MRI scan comes the clinical correlation and the challenges of how you clinically correlate, because Google will say that there's a lot going on with the report. But in essence, it's one way we have to sort of clinically correlate with your symptoms. We can look at some anatomic variations. We can look at some condition-specific pathology and what investigative modalities would we need in terms of bespoking management and specific treatment to our patients. So if you look at if you generally divide sort of the spine into your sort of anatomic region of the cervical, thoracic, and lumbar spine, I think it's important to then realize that there are some specific variations which can occur within the particular region. So for example, in the neck, you've got a larger range of motion. It's complex, it's multi-directional. But you also have the cervical spinal cord, which is the extension of the brain which sits within that. So in terms of any compression of the cervical cord is likely to produce, in most instances, symptoms, which is likely to progress. So you need to bear that in mind. And also in terms of how sort of the normal posture of, I think, the price we pay for being humans, I suppose, in terms of we move a lot, and so it takes the brunt of it. So in terms of how the lordosis might affect as to how the cord or the nerves behave. We then move to the thoracic region, and so if you look at the sort of chest wall as such, because of your ribs, you've got a limited range of motion. So obviously, which is why you don't have a lot of patients complaining of thoracic pain. But if they do, then of course you need to think of red flags, and that's why a lot of our patients come to us with neck pain and back pain purely because of the restriction we have from the chest wall. But also what's important is that you then have the extension of the cervical spine into the thoracic region, and where the thoracic spine is slightly different from the cervical spine is that if you look at the dimension of the canal is much more narrower in the thoracic spine. So in terms of any pathology one might get in the thoracic spine, the scope for sort of any compromise is significantly less. And of course, just like the cervical spine, if you have any pressure of the thoracic cord, you will start getting upper motor neurons and signs. And the fact that your lumbar lordosis from the cervical spine then becomes into kyphosis. So gravity plays a role into that. So my boss used to say sort of life is a kyphosing event, right? It's like, you're all born sort of in the womb, you're all sort of curled up. we stand up straight, and then eventually we sort of all bend forward. So in terms of, it's important to understand the natural history of how posture might contribute to significant pathology. And I think just to be spoken to an individual. If you then move to the lumbar spine, it then says, okay, fine, well, the thoracic spine is kyphosing. How do I keep myself up straight? So it goes back into lordosis. And so with lordosis, what happens is that you've got a larger dimension of the canal. So again, once you have the cervical region, which is into lordosis, the lumbar spine goes back into lordosis, but you've got a larger canal. But at this stage, what happens is that you've got your spinal cord, which then transitions into the chordae equina, or the neurological structures, or sort of pretty much the peripheral nerves. And so the risk of neurological deficit is there, but it's predominantly less than the cervical and thoracic cord, purely because the neurological structures in the lower lumbar spine, i.e. your nerve roots, adapt to this environment. And because it's a much more slower process, they're saying, listen, I'm used to this environment. I'm not going to trouble you unless there's an environmental trigger which declares itself, which is why lumbar pathology is present in a lot of people, but they adapt to that purely because of these slow changes which occur over a period of time. Within that, it's any condition. I think this is not specific to just spine, but any condition in general. Orthopedics, if you sort of divide them into these categories, you're able to sort of pretty much fit them into either problems when you were born, developmental pathology, inflammatory related to rheumatoid arthritis, ankylosing spondylitis, infection, trauma, and for most part of today's talk, we're going to stick with sort of degenerative changes. So if you look at the natural history of a degenerative disc disease, it's influenced by sort of environmental changes, but there is a significant number of changes which occur within the length of the spine, which are beyond our individual control. I just gave an example of a common cold, where you actually take a common cold and you take them through a common cold. The natural history is whatever you do, it's going to annoy you for 7 days. So if you then look at the natural history of what happens to a disc, in the early stages, it's pretty much most of them will have a normal looking disc. You have age-specific genetically predisposed changes which occur. Within that, there's progression and symptoms. Eventually, because of age-related changes, beyond your 70s and 80s, there might be associated spinal canal stenosis with or without symptoms. And there are specific spinal conditions, and we touch base on like a past defect as to how a past defect were to influence. And of course, other significant medical factors or comorbid factors like cancer, infection, trauma, which we touched on. So if you look at a normal MRI scan, so the properties of the disc is that it contains 80% water. And the reason why it's filled up with water and moisture is because the collagen and the proteoglycans absorb and retain the moisture. And what happens within this is that biochemical changes occur within the disc. They are macroscopic changes. And in a significant proportion of the adult population, those changes occur in the background, and a large proportion of our patients are asymptomatic. So what then happens is, if you look at that sort of the diagram on the right-hand side, is a natural history of what happens in individuals when you go from a disc which is normal, it then undergoes degeneration. And degeneration is specific to what we call as age-specific genetically predisposed. So if an individual, let me give an example, if an individual comes to you with pain in their 30s, what we know from those figures on the left is that if we now randomly go up to St. John's Wood High Street and pick up 100 people who have not experienced back pain, and if we scan them in their 20s, 30s, and 40s, the chance of you having an abnormal disc in your back without pain in your 20s is 10 to 15%. In your 30s is 20 to 35%. And by the time you're in your 40s and 50s, half the population is walking around with an abnormal disc in their back and have never experienced symptoms. And I think it's important to start that conversation with your patients when they've come to you with, say, a 1-week history of pain, and their MRI report is 2 pages long, saying there's so many things abnormal. That's because their symptoms in the last 1 week has been driven by an environmental factor based on the changes which have occurred over several years. And it's important to understand, and the classical example I give most of my patients is saying, listen, if you were to come with with a painful knee and you twisted it and you've got a torn cartilage. You tore the cartilage, but you twisted it. It wasn't torn before. But if you've had a fall and you presented with sciatic symptoms and the scan shows a slip disc, okay, the prolapse disc was potentially triggered by the environmental factor, but the disc was already abnormal because a normal disc does not slip. And that process has taken you in excess of 7 to 10 years. So if you look through that chart and saying, if someone's come to you with 6 months of back pain and the MRI says there's disc degeneration, osteophyte formation, Google tells you that that's the end stage of disc degeneration. But what that individual has gone through is at some stage in their adult life, they had a normal disc. It became degenerate, it bulged, it herniated, it healed, and then it degenerated further, but they might not have been symptomatic at a given point of time. So when they present at a given point of time, what we don't understand is that based on a genetic predisposition, based on environmental factors, which individual who becomes symptomatic will fall within that category. And that's the challenge which we face, but I think it's an important conversation to have because that's how you can engage your patients and they start understanding is that all what you see and all what is abnormal might not be necessarily producing pain.
All right, that's a good question.
Of course.
So with the herniated disc, then obviously that part of the degenerative process, with those asymptomatic statistics, is that even for people who might have had a full herniation and still asymptomatic and it's just incidental findings when they would then
I mean, we always see in clinical practice someone's got left-sided leg pain, you get an MRI scan, it shows a right paracentral disc prolapse. They've been through that and they're saying, hold on, I've been told I've got a disc prolapse, but my pain's on the opposite side. And sometimes it's a chemical reaction which produces pain.
Okay.
But there are so many different variations in terms of you're getting a scan done at a given point of time based on the symptoms. I'm a very optimistic man. I look at it and saying it might have been worse than what it was. And the severity of an MRI scan might not clinically correlate with the symptoms. How bad is my scan, doctor? The scans are just as bad as your symptoms, rather than an MRI scan showing that you've got a larger slip disc does not necessarily produce increased amount of pain. What dictates your pain is the inflammatory response. Does that answer your question?
Yes, thank you.
So here's your typical example. So through our practice, you might have all seen a patient who possibly in their 30s or 40s has come with, you can see out there, there's a lytic spondylolisthesis of L5S1. So you can see L5 is slipped over L5S1. For all practical purposes, for all you know, the presentation of this patient might have been that they've had back pain for 6 months and leg pain for 2 weeks. But this radiological change on the X-ray, on the CT, on the MR, has taken possibly in excess of 25 to 30 years to develop in the background and largely become asymptomatic. And that is because if you now go to a nearby school and pick up teenage and adolescent, predominantly girls, but maybe even boys, and if you do an X-ray for all of them, 7% of them will have a past defect and have never experienced pain. There was a study done from Sweden many years back where for some reason, they got ethical approval and they got CT done of kids. This was years ago. And if you were to do a CT scan of, say, 100 kids randomly in a school, 7% of them will have a past defect, either unilateral or bilateral, but have never become asymptomatic. Okay, so now if this asymptomatic teenage adolescent, boys and girls who then sort of go on into adult life, what then happens is that as a result of the biomechanical forces, the disc says, hold on, you haven't healed through your adolescent years. So you're putting a lot of pressure on my disc and the disc starts to degenerate. And the degeneration of the disc along with the past then creates a past defect, which at a given point of time in the adult life becomes symptomatic because there might have been an environmental factor which triggered that. We've been through that. Okay, so in terms of does radiological progression match clinical symptoms, we as surgeons are aware that if you look at a natural issue of a condition by intervention, i.e. by doing an operation, you might alter some of the natural history? And I can give you an example. And is it possible at all based on an individual, whether we can predict those changes? So this lady came to me with significant back pain. She's been under my care for I've known her for about 5-6 years. On the left-hand side, you can see, she's got multi-level degeneration. So she's got, 3 of those discs, which are quite.
Sorry, I'm late.
Quite dark and degenerate. And if you look at the neuroforamen there, you can see the neuroforamen there. She's got severe neuroforaminal stenosis. So she presented with back pain and leg pain. I got an X-ray done, and you can see when you get an X-ray, she's got a segmental instability at L4, L5. So you can see L4, L5 out there is moving much more as compared to L5, S1. And so in terms of how do you manage these patients is you go through an entire range of saying, physiotherapy, injection therapy in terms of how does injection work. An injection reduces the inflammatory response, which produces pain. For most of our patients, when you say inflammation, they equate to inflammation, which you might be able to see on an MRI scan. You can't, because the MRI scan shows you long-standing changes. But it's important to make them understand it's an inflammatory process which equates to pain rather than an inflammatory response which the scan might pick up. So what you're trying to do by giving an injection is to reduce the pain and reduce the inflammatory response, and so that they can go back to those sort of long-standing changes which have been sort of dormant for a little while. We need to speak about sort of lifestyle changes, adaptation and living with pain, and just also to make them aware that surgery is not necessarily a permanent fix for all radiological changes which are present, but also more important for them to understand the short-term and the long-term implications in terms of, yes, you might be better for about 3 to 5 years, but then in your 30s, 40s, 50s, and 60s, and then what happens as a long-term consequences of what you might have done? Because as surgeons, we can, especially with spine, in terms of how the cascading effect is likely to influence the other parts of the spine and influence the short and the long-term process. So based on that, we this is what she had. She had a 360-degree fusion. So those are cages. So the principle remains the same. The principle is there's neurogenic compression, and the neurogenic compression is under a joint. So if you shave away the joint, there's no stability. So you provide stability for the spine. And so if you reduce motion, there's be less pain. And if you decompress the nerves, then they should have decreased less amount of pain in going down the legs. The question here is, we spoke about, in the initial X-ray scan, we looked at that L3, L4 was abnormal. What will happen to L3, L4 in the long term? That's predictable statistically, but for this particular individual, it might not be. But they need to be aware that in 5 or 10 years' time, something might need doing for that stage. And so what I'm trying to say is that surgery is not always the answer for every radiological abnormality. We see a lot of patients, and I think in our sort of primary care and sort of tertiary practice is patients who come with sort of significant back pain, and I'm sure you're all aware of this sort of terminology of modic change in terms of you have 3 categories of patients. So you've got 3 patients who've got pain. You scan the first patient, and their MRI scan is normal. So you're thinking, okay, well, my back hurts, but you're telling me my scan is normal, so why does it hurt? Well, you can still have back pain, but what we have demonstrated is that you do not have a radiological abnormality. So I think it's important to engage, because some of our patients might feel quite dismissive and saying there's nothing wrong with us, but it's important to also make them aware that you can have back pain with normal MR. The second scenario is you've got pain with an abnormal MRI scan. We spoke about those statistics and numbers as to how many of those patients can have abnormality without pain. But modic change is important because it's an edema or an inflammatory change. And there's a study which was done through sort of in Sweden a few years ago, which says that if you were to have those modic changes in your MRI scan, and if an individual experiences back pain, then it's very likely that 94% of patients will present with back pain at some stage. So the chance of you having modic change and not having back pain is only 6%. So that's relevant for our practice as spinal surgeons in understanding that the disc is likely to be producing pain. This is an example of the modic change. You can see sort of that
Kasi ako yata yung nag-prep nito kaya naalala ko yung pangalan. Ay, wala na rin ganito. Oo, sinabi mo ba kay ano? Ano to, follow daw, sabi mo. Ay, wala na follow.
You can see those sort of, if I can bring it, sort of those modic changes. And if you were to do a SPECT CT in this individual, you can see how it brights up. So that brings up sort of in understanding that not necessarily that every abnormality. So if you look at the previous one, the disc above looks slightly abnormal. So you've got 3, 4, and 4, 5, which is abnormal. What's producing my pain, doctor? Well, it's likely to be a modic change. Is there an investigation which can be done to understand which might be contributing to more amount of pain? Potentially do a SPECT CT and saying, listen, you've got 2 abnormal discs. It is very likely that one is producing more pain than the other.
Question.
Of course.
Is that available on the NHS and private?
Yeah. So I work at the Whittington, so we do SPECT CT. Yeah, no, absolutely. My patients at the Whittington get the same. They get a SPECT CT.
Great.
Yeah.
Can I ask you about injections?
Of course.
We've all had steroid injections. That seems to be what you do under guided CT. Nobody ever gives anti-inflammatory injections. Do they work?
That's a good question. So
I know you give steroid injections. We understand that, but we don't know how long they last. And they might last 3 months. They might not. But nobody seems to give any anti-inflammatory injections. Is that because they did? What happens to them? Is it different? Why don't we do that?
that's a very good question. I think it depends, at least in my practice, it depends on how early, obviously with the NHS patients, it's challenging, or they've already seen the GPs who have given them all the medications. Within the NHS practice, within the private practice, in terms of access, if they've come quite early on, I saw someone yesterday morning who's got 2 weeks of sciatic pain, is taking paracetamol. Did I offer them an injection? No, because they haven't taken any anti-inflammatory. So I've given them naproxen with omeprazole cover and asked them to take some cocodamol if the pain is quite bad. And I said, we'll see you in about 6 weeks mark, because the statistics of managing pain with an anti-inflammatory is that 60% will get better within 6 weeks and 80% will get better within 3 months. So there's no point rushing into an injection at 2 weeks, because if you can try a course of anti-inflammatories, it is very likely that there's a 60% chance you'll get better.
Okay, given that we've given them all that already.
Yeah, but you can still wait. I think it's a fine balance. One of the injections I did yesterday afternoon was I haven't slept for 2 weeks. Taking 20 tablets, I'm crawling. They look at you and saying, "You want to wait for 6 weeks," and I haven't slept and I'm in pain. So I think it's a risk-benefit ratio. It's all about saying bespoking. Someone who walks in and says, "I was 7 out of 10. I'm now 5. I'm taking paracetamol." Personally, I wouldn't inject them. I would say, you need to take some naproxen. You need to come back and see me in 4 weeks. I think you're getting better in the natural history and the natural trajectory. If you get better, then you might not need an injection. So I tend to give them anti-inflammatory. So the longer you wait, so after 6 weeks, the statistics basically is that what are the chances of me getting better? Because there are no predictive factors to saying, how bad is my scan? How does my age influence this? What's my intensity of pain? There are no predictive factors to say beyond 6 weeks. So I think most spinal surgeons in the UK, the practice would be try conservative management with medications for the first 6 weeks if you can, if it's reasonable and the patient is tolerating and the trajectory is one of improvement. If at 6 weeks, if you continue to be in pain, you can have an injection, because beyond that, your statistics in the number is small. And what you're trying to do is, if in the natural history, if 90% are going to get better in 6 to 9 months, by giving an injection, you're reducing that period and improving the pain so that they can be much more active and use other modalities like physiotherapy to condition and strengthen. So it's an adjuvant for a painkiller. That makes sense. So just quickly some examples of an MRI scan. So if this is shown to a radiologist with no clinical symptoms or no detailed history, the MRI report will say, on the left-hand side says multi-level degenerative disc disease. As you can see, they're all darker. It's got a right-sided L5S1 disc prolapse on the top right screen. And on the left side, on the lower one at L4, L5, there's a moderate amount of stenosis with some facet changes. So that would be a report. So that's a one-page report basically saying this is all what is abnormal. We all know that the symptoms can then vary. And so this is where we, as clinicians, clinically correlate. So and most spinal surgeons will then divide these radiological changes by taking a history and doing a clinical examination and saying, let's divide this into 3 sources of pain. And the 3 sources of pain is, one is pain coming from a disc, so discogenic pain, which is basically when you sit, when you bend forward, when you hold it. The second is neurogenic pain, which is very sort of clear because it's pain going down the leg. And the second is facet-related pain. So predominantly, you stand up, you arch backwards, ouch, it hurts. So I think if you differentiate, and of course, there will be an overlap in patients between the 3. But I think it just helps you in saying, that's the history, that's the clinical examination. And so when you then look at the, go back to the MRI scan and saying, okay, what produces discogenic pain? It's localized lower back pain. It's worse on sitting and bending forward. This is something, I've got a child at home, I just can't lift him or her up, it's really painful. And when I just arch myself backward, I just feel a bit more relieved. So that's more discogenic pain. So you can radiologically and clinically correlate with the symptoms. That's most obvious. Ouch, my leg hurts, and you can see why, because there's a disc which is pressing on the nerve. So if this individual had right-sided leg pain, then the clinical correlation of the same scan means that your pain is coming because the disc is pressing on that nerve. And what we need to appreciate that is that it's not necessarily the mechanical pressure which produces that S1 radiculopathy. It's the abnormal chemicals which are released by the nerve. So what you develop is what is called as chemical neuritis. So it's the chemical neuritis which influences the pain. So the rationale of this person having an anti-inflammatory or an injection is that by injecting steroids or taking an anti-inflammatory, you're decreasing the chemical neuritis of the disc on the nerve with the hope that 2 things happen. The first thing is that the disc in the natural history will heal. The second thing is, as you have less amount of neural irritation, then you have less amount of pain. I think what patients like to also know is that by injecting, you are not masking pain, because for a patient, it is, you've got a disc pressing on my nerve, you're giving me an injection, I'll get better, but it is my nerve susceptible to nerve damage that does not occur. So it's also reassuring, saying this is pain management, getting that duration down and addressing your symptoms because of the inflammation.
And that's all targeted around the inflammation.
Correct. The inflammation, which is the chemical neuritis, which
Yes.
the disc produces on it. Facet-related pain. So if you then go back and look at the same scan and saying, oh, actually, I don't have any leg pain, but the report says I've got a disc pressing on my nerve. Yeah, it's not necessarily, because the nerve is adapted to the environment. The nerve is saying, that's fine. You're sitting on me and you're pressing me, but I'm not going to trouble you. And that's okay, because that nerve is not susceptible to more damage. So facet-related pain is pain on standing, relief or flexion, and then it's extension related. So, and most people will say, when I just can't sleep on my back, doctor, it's just so painful, because when we lie flat on our back, we extend it. So they'll say, I'm so comfortable when I lie on my sides, I bend my knee, I curl up, and it's a little bit comfortable. That's just sort of a general overview. I know it's half one. There's a general overview of just looking at different pathology and understanding back pain and the radiological challenges. I can quickly go through 2 or 3 specific common conditions which we come across in our mutual practice. I'm happy to take any questions and have a discussion, so I'll be guided by you guys.
How many of your colleagues are putting in discs into backs?
Disc replacement? Not a lot.
No.
Not a lot. I think that it's changed. I think we've gone one full circle. Again, it depended on where you got trained. It was based on evidence, was significantly driven by the US and European market. let's not go there. And so there was a certain amount of bias, but also a certain amount of sort of placebo effect from a patient saying, I am having a disc replacement rather than a fusion, so I should be better, and I think I'm better. But if you look at the scores, they weren't. So the present evidence we have in terms of disc replacement for the lumbar spine, in terms of managing pain, is that L5S1 is not suitable for disc replacement because of the angle in which L5S1 sits. But if you feel that L4, L5, a patient is still suitable for a disc replacement at 4 point, biomechanically, it's a bit more parallel, so you can still do a disc replacement. So that's our present understanding. I don't believe in it purely because of the long-term implications, but for completeness, I shouldn't be biased because I fuse. I do mention it to them and saying, listen, you can have a disc replacement. In my personal opinion, it's not going to work because of ABC, but they need to know, because otherwise, as a surgeon, you're biased about a particular procedure which a patient might benefit. But generally, if you look at the data within UK, the number of people doing lumbar disc replacements. So I do a lot of cervical disc replacements purely because of the biomechanics, but the lumbar one, not a lot.
Does anybody have any questions online?
Sorry, and in I was having problems connecting. Thank you.
Can I ask one more? Of course, some of your
I've got a question as well in a minute.
name.
Would you like to go first online?
Yes, Oliver from the Princess Grace Physiotherapy. Just wanted to ask, a while back, probably a couple of years ago, endoscopic discectomies was it was in fashion. Are many of your colleagues still doing it, or is it just better that they still just do a small incision now?
Hi, Oliver. Good question. It's still. I think still there's a few of my colleagues still doing endoscopic surgery. It's still there about, and the learning curve with spinal endoscopic surgeries is really steep. You're talking about sort of years. We don't have enough data to look at conventional microdiscectomy versus an endoscopic disc in the lumbar spine. But what's coming out more from, especially from sort of Germany and some of the European centers, is cervical endoscopic decompression. So you sort of for foraminotomies, instead of making a big cut with sort of predominant neck pain as a consequence of that. But the challenge you have is before you start doing cervical endoscopic surgery, you need to get numbers for lumbar surgery in terms of high volume. So I think it's restricted to centers, and I think the way forward as a society within the UK is that you need to have smaller, because there's a tendency saying, oh, I can do endoscopic surgery, and I end up doing one, and that's why I don't do it, because I don't have a practice and I don't have the number. So there's no point doing 1 and 2, because if I do 1 or 2 a year, I won't get good at it. So I think it's best to have people who saying, okay, you do all the endoscopic stuff, you get your numbers. And I think there's a specific sort of feel for that, where I think a small cohort of patients would certainly benefit from that. So yes, it's still there, and I think that practice is still getting stronger and stronger within UK. But I think we need centers to do a lot more, and just a small number of people doing it rather than many surgeons doing fewer numbers.
Yeah, thank you.
I think just off the back of that, I think there's a new consultant starting for endoscopic spinal discectomies in the PMC as day cases, I think, starting in the next month or so.
What's your view about some of the professors at vast expense of spinning platelets and sticking platelets into people's backs with their discs? What's the pathology behind that? I mean, there's knee surgeons who do it, but now many of them have said it's a waste of time. So some people have put spun platelets, your own platelets, into your back. Well, I'm sure you know all this.
Yeah.
Anyway.
Yeah. I know it's happening. I don't have much experience with that. In terms of, like I said, on most days I struggled. I still, been a consultant for 17 years now. I still struggle to understand back pain because there's a one-page report and the patient symptoms don't match. and then you got clinical symptoms which don't match with radiological findings, and then you're putting something into someone's back which which there's no evidence from, and it's largely unreliable. So it's not something which I've come across before. The only thing I've come across is someone from the southwest who had very similar thing and then ended up having a discitis in the back with infection because they had sort of platelets in the disc. And a disc is a very avascular structure. But if you go back to many years back when we were trying to understand how disc produces pain before we had the SPECT CT. So before we had SPECT CT, if you wanted to understand how back pain, what's the source of your back pain, you did a discogram. So you get the patient under sedation. You would put a needle into a normal disc and they said, doesn't hurt. So you think, okay, good, well, because it's normal. And then you would put a dye into an abnormal disc and they said, ouch, it hurts. You think, oh, that's abnormal. And then you fused it. That's what happened before you had SPECT CT. And what we didn't know is that if you infiltrate the disc or the annulus, it is very likely that the disc will progress and have degenerative changes, which is why discogram over the years went into disrepute. So generally, injecting anything into a disc, whether it's normal or sort of degenerate, to me at least doesn't make sense, because you sort of change those sort of genetically. So I tell my patients and saying it is genetically predisposed, age specific, based on environmental factors, which is why you're experiencing the pain. And I don't think by infiltrating something in the disc you're going to change that. Change your parents. That's not any other questions?
Yes, I've got one question.
Sure.
You find that after surgery, you find that the patient still walks with a disturbed gait and balance, and the clumsiness with their hands still persists. What's the way forward with that?
With cervical myelopathy?
Yeah.
Okay. Yes. So the natural history of cervical myelopathy is that when you have, as you can see there, when you can have a disc which is pressing on the spinal cord and they've got signal changes in the symptomatic, they fall into three categories. So the first category is 75% of patients will have a stepwise deterioration. 25% will progress rapidly, and 5% might have a fall because of the unsteady gait.
Yes.
And might, if they were to have a whiplash type of injury, then they will get a central cord syndrome, which means they will be having significant neurological deficit. So in the 95% of our patients who are having sort of early planned elective operation for cord compression, it's important for them to understand that the rationale of your treatment is to preserve function with the hope that they don't get better, they don't get any worse. Okay,
Right.
so fine. So I've operated on someone a year ago. They've come back and saying, doctor, I don't think I'm any better following the neck operation. And the question I normally ask them is, are you any worse? I'm hoping for them to say I'm not any worse than what I am, because that's a good outcome. But of course, when you're going through an operation, you want to get better. That process of getting better can take 2 to 3 years. That's unpredictable. So I think it's preserving function. So if your patient has come back and said, I've had an operation, but I'm still unsteady and I'm still, clumsy in my hand, what the surgeon has done, surgeon has prevented progression of their symptoms, which is why they're not getting better. But at some stage, they would, if they came back in 6 months and saying it's the same, I would potentially rescan them, because if there's any residual compression, then you might need to reoperate. But generally, most or some of the patients might come back and saying, I'm not better than what I was. That's because we have prevented progression. So it's very likely that your patient who came back to you just did not get better because they weren't going to get better.
All right. Thank you. Thank you. It's Miles, by the way. This Grace.
How are we for time? Fine.
Yeah, we've got about 10.
10 minutes. Okay,
Yeah.
So I think we covered on myelopathy. So we spoke about that. Let me just skip this. What else do I have here? Just bring. Okay, so in terms of sort of going down the route of cervical disc prolapse, we spoke about the natural history. So the natural history is one of progression. 60% of adults between the age of 25 and 50 or 60 will develop sciatic symptoms in their lifetime. That's the statistics. A significant proportion of those patients will get better just with time, i.e. 90%. When they have a first episode of sciatica, 60% will get better within 6 weeks, 80% will get better within 3 months, and beyond that, it's slightly unpredictable. So if you were to sort of intervene, then your intervention is predominantly based on conservative non-operative management and management with an injection. And what you're trying to do with an injection is, as we discussed earlier, decreasing the inflammatory response. And by decreasing the inflammatory response, you're basically allowing the natural history to settle down with a period of time. 10% of patients without any predictive factors might continue to have pain. They've had injection, they've had 2 injections, and they're like, Rohit, it's now 9 months. This is clearly influencing my quality of life. It's really painful. I've had 2 injections, I'm taking medications. I can't carry on with that. So the conversation I have is, it's unpredictable from here on. We can just manage this non-operatively. You don't need to have an operation. This is all based on your pain and quality of life. But it's already been 9 months. You're outside that natural history of how most people would have settled down. The conversation then occurs around surgery, which basically is a microdiscectomy. And surgery gives you much more predictable outcomes, which means when you have a microdiscectomy, there's an 85% reduction in your pain. 70% of your patients will be completely pain-free. 25% will be significantly less. The chance of you having a complication or anything going horribly wrong is less than 1%. And the risk of neurological deficit is 1 in 1,000. So you have a low risk and a high benefit operation. The only reason why we might want to see patients sooner rather than later is when they have neurological deficit. So if someone's got a foot drop or an S1 deficit, it's time dependent. So 7% of those 60% patients who develop a sciatic pain will have a neurological deficit. And the neurological deficit relating to your foot drop or an S1 deficit is predominantly related to a vascular event. Something happens to the nerve and the nerve just sort of dies and sort of may or may not recover. The discussion at that stage is based on their symptoms and based on how functionally they feel troubled by it. So a few weeks back, I saw someone who's got a dense foot drop, was referred by one of my GP colleagues with persistent pain, a large L4, L5 disc resting on L5 with a foot drop. He was 2 weeks down the line. The conversation at that stage is, you're 2 weeks down the line, you can wait and see if you get better. I normally don't tend to have a conversation about injection because I'll just mention it, why muddies the water. Or the second or the third option is that you can have intervention because it's a time-dependent condition. As you can imagine, with neurological deficit, you can't have randomized controlled trial to saying, you go home, you have an operation, let's all catch up in 6 months and say who did better. You just can't do that ethically. So the only evidence we have, and I've been involved in one of the studies, is timing. And the timing is usually about 4 to 6 weeks. So if you pick them up, you need to intervene within 4 to 6 weeks because it's a time-dependent condition. And the only other thing which might influence the outcome is diabetes. But what we know is that it's a time-dependent condition. Now, if this individual came and said, can I have an injection? Okay, you can have an injection because you've got 3 scenarios. So 2 weeks of pain with a neurological deficit. If you were to have an injection, the first thing is the injection can take 1 to 4 weeks for it to work. So if you go down the route of an injection, you have to make sure that you're given it time for it to work. You can't say a week later it's not worked, so let's do an operation. That's the first thing. You then have 3 scenarios. One is the pain's gone and the foot's improved. It's win-win situation. You don't need an operation. You can manage with physio and lifestyle changes and stuff. The pain's still the same and my foot's not improved. We can revisit a conversation of intervention. The third scenario is the most challenging. You've done an injection at 2 weeks. They come back and in 2 or 3 weeks time, they're saying, my pain's gone, 0 pain, but my foot's not functioning. What do we do? it becomes a difficult conversation at that stage because you can still discuss an operation, but you're discussing an operation for a microdiscectomy for an unpredictable outcome because I don't know whether you will get better or not with this operation. But if you had pain with your foot drop, we know that if you had an operation early on, your pain would get better and the nerve would be in a better environment for it to heal. And so the third scenario becomes challenging. And I think I first see them, I take them through these three scenarios and let them sort of decide. But generally, I think the practice for most spinal surgeons within the UK at present is if you've got a neurological deficit, I'm not saying rush into it the same week, but I think make them aware that it is a time-dependent condition when it's associated with pain. I think when it's painless, it's a little bit more challenging because pain is not an issue. So you can get a painless foot drop. And the painless foot drop, there's still some evidence, and me and my colleagues from Whittington published a paper in the Bone and Joint Journal a couple of years back saying in a painless foot drop, the chance of your recovery, if you were to pick them up within 3 to 4 weeks, is about 75%. So our present practice is that with or without pain, a discussion quite early on neurological deficit is quite important with the patient. If someone comes and says, listen, it's 6 months now, my foot's not functioning, we need to do something about it. It's a bit too late because you missed the boat. 10 to 2, I think we'll take some questions in.
Yeah.
Sorry, there's a lot to cover, but I just thought this is the most sort of relevant in terms of just understanding back pain and radical symptoms. So the cervical spine is very similar. I didn't touch much on cervical spine apart from myelopathy. So generally, my practice with lumbar and cervical radiculopathy is conservative, non-operative, non-steroidals if there's no contraindication. I'd be guided by you guys about neuropathic tablets. I get told off with a lot of my GP colleagues about pregabalin. It's like, Rohit, stop it, don't, because they are so, but pregabalin works, but then the risk of being dependent is like, I have a patient, I'm doing a revision microdiscectomy next week, and she's like, I'm taking 450 of pregabalin. Actually, I'm quite good. And I was like, but I don't want to be on that. And it's like, it's 5 months now. She's a journalist, and she's like, I just can't function this way. And can I have an operation? I said, well, you're not having an operation when you're on 450 of pregabalin, when you don't have pain, because I don't know whether you're just getting better on your own or whether it's the pregabalin. So what I've told her is that, this was 3 weeks back, I've told her is that you need to go away and reduce your pregabalin because she's been taking it for 5 months. So she's reduced her pregabalin, her pain's gone up. She's contacted me this morning and saying, can I see you on Friday? Because I just can't take 450 of pregabalin because when I've reduced it, my pain's come back. And that's the conversation you have. It's just about using common sense and saying pain has been managed by pregabalin. And there's a risk that if you continue pregabalin for a long period of time, that you are just, you're dependent on a medication for managing your pain. And at what stage as a surgeon do you introduce and saying risk benefit ratio of an operation versus taking pregabalin for months and months. So I do get told off by GPs saying, oh, you spinal surgeons, amitriptyline, gabapentin, pregabalin. There is a role. I'm not saying you should be taking for 3-4 months, but for a short period of time, I still believe that if you give them and if it works for them, then you can hopefully avoid the need for an operation. So why operate when it's not required?
So what's the sort of time spell that?
It's a good, yeah, it's a good. I think the evidence we have for with the neurological deficit is different. The evidence we have from the North American Spine Society and from our local study from Oxford in terms of timing for microdiscectomy is 6 months. That's an idea in terms of when do we tell our patients that you have exhausted non-operative management. Is usually the 6 to 8 month mark. But 6 to 8 months with pregabalin is still a very, very, very long time. And I think for a short period, I think, I speak to some of my neurology colleagues and I ask them and saying, what is the fine balance? And they say, oh, it's 6 to 8 weeks, and then sort of, gradually increase it, start with 50, go up, and then just slowly taper it down with an injection. So introduce an injection, get the pregabalin in or amitriptyline with your anti-inflammatory. And if the injection works, reduce your pregabalin and then reassess. I don't think that's the right answer. I think every individual is slightly different. Mm-hmm. I think you have to bespoke based on how bad their pain is and how this is influencing the quality of life.
And my experience as a physio is that amitriptyline's used more for arm pain. Is that right, that it's not really used for leg pain?
We do. I mean, I give amitriptyline for radicular symptoms. So generally, the principle is the same. Like, I mean, in smaller dose, so I start with 10. Some of my neurology colleagues goes up to 40. The maximum allowed, I think. Correct me if I'm wrong. But generally, yeah, the side effects is pregabalin. My understanding is slightly better, but a controlled drug, but slightly more effective than amitriptyline with all its side effects. It's always risk-benefit ratio, isn't it? 5 months of gabapentin. My challenge with this lady next week when she's having an operation comes of gabapentin is dependence. So I'm going to get a pain management consultant involved in sort of tapering it down, but also sort of post-withdrawal psychosis with pregabalin. That's massively unrecognized.
So I have 2 questions.
Sure.
With this journalist who's probably very busy and dosing herself off on this medication, do you give any advice in terms of what she should and shouldn't be doing? Is she having any physio as well?
Yeah, she's having physio, lifestyle changes, many.
And is she doing that? We don't know. Okay.
She's not been going to work. That's she said. She said, I just can't go to it. I just can't travel. I have to use public transport. She lives in North London. She works in town. And she's like, I'm finding it difficult. I work from home. I can't sit. When I sit, it hurts. When I stand, it hurts. I can't sit. And it's just, I can't sleep. So she's really struggling. But yes, I've said, I send them to physios, and physios are, we can't touch them. They're in so much amount of pain. And then you increase your medication, and it's like, well, it doesn't hurt now. And then on a good day, correct. And on a good day, you push them for the exercise, and 2 days later, it hurts because the inflammation is built up. So it's very, yeah, you're right. I mean, in an ideal world.
Well, I think they're going to need hand holding. I think it's that vicious circle that needs to, and I don't speak. And the second question was that in your post-pregnancy, postpartum patients, when they've had epidurals, have you had any experience where the trauma from the needle has caused any issues with the disc?
No, I mean, it probably doesn't go as far as that. I mean, yeah. So, I mean, yeah, and I get that, once every few months in saying my back pain started after my epidural, and then I had an MRI scan, and then I had 3 abnormal discs. And, the way to look at it is like the 3 abnormal discs was there for 10 years. We did not have back pain. This was an environmental factor which might have contributed. It's difficult to, because they were like, for a patient, and we need to be cautious that they don't feel dismissive and saying, no, it's not the epidural, because it's not. But there's some correct, some environmental change in the biochemical change within the dura, within abnormal pre-existing disc is likely to have contributed. Just being a bit politics.
No, I get it. That's fine.
We're just looking after our colleagues because it's not the epidural which produced it, but it's also the 3 discs which was degenerate.
Well, they just come in and say, I had this epidural, and actually they put the 2 together, and you're trying to unpack it for them, but it's very hard to. So I thought
absolutely. I don't, it's just making them understand that, listen, 20% of the population around your 20s and 30s will have an abnormal disc. So this environmental change, along with postpartum sort of core muscles, quads, hamstrings, a combination of all of that, there are many small contributory factors which is likely to have sort of produced your present symptoms.
Does smoking affect the disc?
Yes, that's the only thing which we have in terms of the only evidence, and I know a lot of some of my colleagues will definitely not touch patients and do a fusion if they're smoking and saying give it up for 3 months before and 6 months after.
Do you?
I mean, I try. I try, and they tell me that they don't. It's one of the things. How much is she doing? It's how much as clinicians and as physicians, how much do you advise and what do they take on board? Because no one wants to be unwell. They all want to get fixed ASAP, but they want to continue doing what they want to do. And
what does the actual? Is it the nicotine that affects?
Correct. It's the antioxidants within that, and in terms of how it affects the proteoglycan and the collagen content. In terms of, but also the bone in terms of fusion. For us, it's a fusion. So that's basically what it does, sort of in terms of at the molecular level. There's some changes which.
And is it the same with vaping?
I don't know. I don't know the answer, but cigarette, yes.
Yeah, I've got a few questions online. Oliver.
Yes, I just wanted to ask, with the change in society, are you having to have quite frank conversations with the challenge of obesity? Is that you have the scan and you actually have to have the frank conversation with a few patients now saying you actually really need to lose weight?
Although some days I feel like a psychologist sitting in my clinic. And I finish an all-day clinic, and I said, I haven't spoken about spine much today, which is fine. I think it's all about taking patients through that journey. I think we know from hips and knees that higher BMI, and correct me if I'm wrong, higher BMI has no significant difference in the outcome. My experience, and with all due respect to my North London patients, my NHS practice, I love them, is we have a significant cohort of patients, literally. The last time I did it on a very small, in a low BMI, I was struggling because I'm so used to patients with higher BMI. It does affect the outcome. I think it does. I think that the patients, personally, I think the patients who come and say, listen, I can't lose weight because I'm in pain, will never lose weight even after you take away the pain. Okay, that's just how they are. It's just so. So does it influence the outcome? Maybe a little bit. Yes, we've got a bariatric unit. So if there's someone massively high BMI, I'm like, no, I think the risk-benefit ratio is the risk far outweighs the benefit. So I would say you need to go have a consultation with a bariatric surgeon and then come back, because when you come back, you might not have that much pain, but we can discuss surgical options.
Yeah. And sorry, last question. Are you a believer? Will you send I know you send them to physiotherapy, but if the patient was to say to you that they're doing Pilates, do you as a surgeon believe Pilates is useful?
Yeah, absolutely. I think the way it should be is that you guys need to be looking after our patients and then sending them across to us for management of pain. I think generally we are, basically guiding you into saying it's okay to carry on and it's safe to carry on.
And then final question.
Thank you very much.
If you know my Les, she's from the Whittington.
I've got two questions, quick ones. The first one is, I know you mentioned pregabalin as your preferred neuropathic pain relief. Have you ever tried gabapentin in the neuropathic pathway? Sorry?
Me personally?
I know you talked about pregabalin as your preferred neuropathic pain relief, but I'm just asking if at all, I know somebody also talked about amitriptyline, but have you ever considered gabapentin as well for the neuropathic pain? That's number one. Then the second is, obviously we need to get these people moving with whatever device, if they've got a drop foot, whatever device we can. And then we would probably ask for maybe, would the TENS help? Would you refer them to the pain clinic? I don't know if at all there is any coordination with that.
Yeah, so the neuropathic tablets, my experience is predominantly based on my referral to my pain management consultant and neurologist. So that's where I get it from. Because as you might know, as of April 23, pregabalin and gabapentin is a control drug. So I don't prescribe control drugs. So I have the option of giving them amitriptyline, but then sending them off to a pain consultant or a neurologist. So all the letters which I get back says we discussed the risk-benefit ratio of everything, and they all seem to be on pregabalin. So that's my understanding based on at least the pain management consultants and the neurologist. So I personally don't. So I say this. I say, because you get, dryness of mouth, withdrawal symptoms, there's so many different side effects. And so I normally leave it to either our GP colleagues or the other clinicians to decide on that. So I don't have a preference. Sorry if I said earlier that I would want my patient to be on pregabalin. It's just saying a form of neuropathic tablet based on an individual's risk-benefit ratio.
Right. Thank you.
So in terms of pain management, so I do a lot of referral to pain management and vice versa. I think if there isn't a surgical target, then I think sometimes the challenge is that if you sit along with the patient for a prolonged period of time, there is this anticipation that I'm seeing a surgeon and there is an abnormality and he's going to fix me, and you don't want to go down the route of you don't want to go down the route of saying you had 3 injections and now you're saying, sorry, I can't help you because I thought I was going to have this amazing operation and I'll have my life back. And I try and avoid that by making it very clear quite early on in terms of what we can achieve. So if there's usually a non-surgical target where I know that any more than facet joint injection is all what they require, then I tend to do an early pain management referral.
Thank you. Thank you so much.
You're welcome.
Anybody else have any final questions? Amazing. Thank you so much. Thank you for joining online. I'll circulate Mr. Shetty's contact details. Thank you very much.
Thank you for your time. Thank you, Holly and Alec and Bilal. Thank you.
You're welcome.
Thank you
Bye-bye.
very
Thank you so much.
Thank you. See you.
Bye.
Bye.
Bye.